This is Dr. Donald Leung, Editor-in-Chief of the Journal of Allergy and Clinical Immunology. Joining me today is Dr. Linda Schneider, Director of the Allergy Program at Boston Children's Hospital and Associate Professor of Pediatrics at Harvard Medical School. We also have Dr. Rachid, Director of Allergy and Immunotherapy at Boston Children's Hospital and Assistant Professor of Pediatrics at Harvard Medical School. I'm delighted to have the opportunity to discuss with Dr. Schneider and Dr. Rachid about their recent article in the December 2013 issue of JACI entitled A Pilot Study of Omalizumab to Facilitate Rapid Oral Desensitization in High-Risk Peanut-Allergic Patients. Dr. Schneider, can you tell us what was the clinical problem that you wish to tackle?
My colleagues, Dr. Dale Umetsu, Dr. Rachid, and I wanted to develop a treatment for food allergy. And for this study, we focused on peanut allergy. Food allergy is a major public health problem that affects an estimated 3 to 4% of the United States population. Peanuts and tree nuts are particularly problematic as reactions to these account for the majority of deaths from food allergies. Unlike milk or egg allergies, most patients with peanut allergies will not outgrow their allergy. Peanut allergy has a significant impact on quality of life for patients and families. Over the last several years, there have been reports of success with oral food allergen immunotherapy. However, reactions are common, the procedure takes several months, and a significant number of patients are not able to be desensitized.
Dr. Rachid, what was your approach to address the problem?
Food allergies are the result of a person's immune system reacting to a food. When that happens, the immune system produces food-specific IgE antibodies that trigger an allergic reaction when that food enters the person's system. Omalizumab is a humanized monoclonal antibody that binds free IgE and is approved by the FDA for the treatment of asthma in patients who are 12 years and older. Dr. Leung, you and your colleagues showed several years ago that just giving a related anti-IgE used without oral peanut desensitization increased the amount of peanut the subject could ingest. We hypothesized that oral desensitization to peanut may occur more rapidly and with greater success when combining it with an anti-IgE therapy. In our study, we included 13 patients, aged 8 to 16 years, who had a history of clinical reaction to peanuts. Their mean peanut-specific IgE was very high at 229 kilounits per liter, and this is the highest that we know of any peanut desensitization study. As shown in Figure 1, patients had to fail an initial food challenge with a peanut flour dose less than 100 milligrams, which is equivalent to less than a quarter of a peanut. Patients were then treated with omalizumab for 12 weeks, and then they were admitted to the research unit for initiation of the oral desensitization. They received 11 incremental doses of peanut flour, starting with a very low dose and ending with a cumulative dose of 992 milligrams of peanut flour, all administered over only 6 hours. This is equivalent to about 2.5 peanuts. All subjects returned the next day to the research unit to start the slower updosing escalation phase, beginning at 500 milligram peanut flour or a peanut and a quarter. Patients continued to receive their daily peanut doses at home and came each week for an increase in their dose until they reached 4,000 milligrams of peanut flour or 10 peanuts. At that time, we stopped the omalizumab and daily oral peanut dosing was continued. A second challenge was done 12 weeks later for up to 8,000 milligrams of peanut flour or 20 peanuts. Afterwards, The subjects were asked to continue on ingesting 10 to 20 peanuts orally every day.
Dr. Schneider, what were your results?
Well, during the initial food challenge, all of our 13 patients had significant allergic reactions to less than a quarter of a peanut. And in fact, 6 of these patients required epinephrine. So it just shows you how highly allergic the patients were. After 12 weeks of pretreatment with omalizumab, the patients had their desensitizations and did very well. They developed minimal symptoms. 2 patients needed antihistamines, but no patients required epinephrine. For the next 7 to 12 weeks, their daily dose of peanut was increased to a total of 4,000 milligrams. One subject withdrew during this updosing phase after he developed persistent nausea and hypersalivation. For the remaining 12 subjects, the omalizumab was discontinued and they were able to continue on their daily dose of peanut. At the time of the next food challenge, 11 of the 12 patients tolerated the food challenge. 1 patient vomited at the last dose of the challenge. However, subsequently tolerated an open challenge with 8,000 milligrams of peanut, or about 20 peanuts. So therefore, 12 of the 13 patients tolerated 20 peanuts after completing the study. After they had their final food challenge, they continued to take 10 to 20 peanuts every day. During this study, we were especially concerned about safety, and Table 2 shows our safety data. There were a total of 72 reactions during the study, or 2% of the over 3,500 total peanut doses which were ingested. Most of these reactions were mild and occurred during the updosing phase. 25 of the 72 reactions occurred in one subject and were mostly episodes of nausea and hypersalivation which lasted for 15 or 20 seconds. In other subjects, most of the reactions were mild and were easily treated by observation or oral H1 and H2 antihistamines. Importantly, 6 of the 13 patients had either no reaction or a single grade 1 allergic reaction. 6 of the 13 patients did experience a grade 2 or 3 adverse event. 3 patients received epinephrine for grade 2 or 3 reactions. 1 patient withdrew after having 3 reactions during the maintenance phase, as his parents were concerned about significant anxiety. As reported in other studies, reactions were associated with triggers such as exercise, menstruation, NSAID use, or concomitant viral infections.
Dr. Rachid, what is the significance of your findings?
Our results suggest that the desensitization to amounts of peanuts often associated with contamination and accidental ingestion can be achieved pretty rapidly after only 12 weeks of omalizumab therapy and only 6 hours of desensitization. The 2.5 peanut milestone would be likely enough to protect them from trace exposures, and that alone is encouraging because trace exposures is a serious problem in the allergy community. Desensitization to much higher amounts, such as 10 or 20 peanuts per day, as we saw in our studies, can also be achieved rapidly. In other desensitization studies done without anti-IgE, on the initial day of the desensitization, only 21 to 26% of patients tolerated a cumulative dose equivalent to a quarter of a peanut. Because of the high frequency of allergic reactions associated with oral desensitization without omalizumab, more recent studies have limited the maximum dose on the first day to a cumulative dose equivalent to only 24 milligrams of peanut flour. Our patients who were enrolled had a very high median specific IgE, actually the highest of any study we know of, and they were able to tolerate much higher doses in a much shorter period of time.
Dr. Schneider, what was the impact of the study on the participating patients, and what were the challenges they faced?
We are currently analyzing the quality of life questionnaires to evaluate the effect of the desensitization on the quality of life of our patients and their families. They have expressed significant satisfaction with the ability to eat new foods without having to worry about the risk of cross-contamination from peanuts. Some patients have had significant aversion to the taste of peanut and are tired of having peanut daily. We've been working with the families to help them find methods to ingest peanut in different ways, such as eating it in baked goods, M&Ms, or even swallowing peanut flour capsules. A few of the patients have developed anxiety after developing allergic reactions.
Dr. Rachid, have you evaluated tolerance or immunotherapy to determine if you have been able to achieve a cure in these patients?
The ultimate goal of food allergy immunotherapy is cure, resulting in permanent tolerance as defined by the absence of symptoms after ingestion of the food, even after prolonged or erratic periods of avoidance. In our study, the median specific IgE of these patients has decreased significantly, but is still elevated at week 52, suggesting that cure may require much longer periods of therapy in these patients. Our current recommendations to our patients is to continue to eat their peanut dose daily. We are currently following them up, and we expect the study to at least last for 3 years, if not longer, and we may consider spacing their peanut doses depending on their peanut-specific IgE, as well as the patient's and family's willingness or interest in doing so.
Dr. Schneider, what were the limitations of the study?
There are significant limitations for this study. This was a small pilot study that enrolled only 13 patients. There was no placebo arm. We do feel that larger studies are needed, and we are currently conducting a multi-center placebo-controlled trial at 4 sites at Boston Children's Hospital, Children's Hospital of Philadelphia, Lurie Children's Hospital, and at Stanford. And with this study, we plan to evaluate further the role of omalizumab as an adjunct therapy to oral peanut immunotherapy.
Dr. Rachid, what are the key messages of your study for clinicians taking care of patients with peanut allergy?
Our key messages for these clinicians is that the use of omalizumab as an adjunct therapy for peanut oral immunotherapy has shown promising preliminary results in this small pilot study. However, some patients have developed significant allergic reactions during the maintenance phase, and therefore patients undergoing desensitization need to be closely monitored. As Linda mentioned, we feel strongly that larger studies are necessary to determine if omalizumab is indeed an effective adjunct therapy to oral immunotherapy in inducing rapid desensitization to either doses that would help prevent reactions from accidental exposures or doses that are even higher.
Dr. Schneider and Rachid, thank you for joining me today to discuss these very interesting observations, and we look forward to hearing more about your results from future studies.
Thank you, Dr. Leung.
Thank you for having us.
You're welcome, and thank you.